So I'm breaking my talk into two parts. What we would like to do is talk about where we're going with multiple sclerosis, but this morning we're going to talk about where we are with multiple sclerosis. I always feel a little bit guilty doing these lectures where we're doing some basic stuff, because I know most of you could get up here and do this talk just as well as I could. Just to make sure we're all on the same level playing field, we're all going to go over a few of the basics of MS. Some of the slides that you have in your handout, I'm not going to go over, but you've got them there for information purposes. So, how does the central nervous system work in humans? This is the way that things should work. This is a myelinated axon in the brain or spinal cord. So you've got the nerve fiber, the axon, and then you've got the insulation, the myelin. And you'll see the little gaps in the myelin. So to me, again, I'm very food oriented. Those look like sausage links on end. Those gaps are called nodes of Ranvier. They're little areas where there's no myelin. And the way things normally work is the electrical potential jumps from gap to gap to gap. It's a very fast, very efficient way of getting information from point A to point B in the brain and spinal cord. So that's the way things should work. And then multiple sclerosis comes in and throws in its 2 cents worth, and we have a demyelinating condition. So here now the insulation is being stripped away. That normal electrical conduction where it jumps from gap to gap to gap can no longer occur. And so what ends up happening is that as long as the nerve fiber is still intact, you can still get information across that area, but it's not as fast and it's not as efficient, and it will always be the weak link in the electrical conduction chain. We'll talk a little bit about heat sensitivity in a few days, or exertional weakness. Heat sensitivity and exertional weakness are due to this. This is from the demyelination. In 1998, a guy named Bruce Trapp up at Cleveland Clinic showed that MS can do more than that it not only damages the insulation, that it can cut the wire. And so Dr. Trapp showed in some really elegant studies that there was early on in MS this nerve fiber damage. If you cut the wire, there is no electrical conduction. So that's a done deal at that point. Ironically, we took that as a pretty big discovery in 1998. But if you go back, way back, 1868, and you look at some of the papers from Dr. Charcot, the father of modern neurology, in Paris, he said, you know what? MS does more than just demyelinate. It actually cuts the nerve fibers. But somehow we lost that over the next 150 years in French translation. So we should give Dr. Charcot his due credit. So what does MS come from? So we know that with multiple sclerosis that there are both genetic and environmental influences. MS is not a single gene disease. There are health conditions out there that are what we call autosomal dominant or autosomal recessive. If you have an autosomal dominant condition, if your mom or dad has that health problem, you have a 50-50 shot of getting that. An example of that would be Huntington's chorea. We have genetic testing for Huntington's chorea. We can test an 18-year-old and tell that person whether or not they're going to develop Huntington's disease later in life. Autosomal recessive conditions means if your mom or dad has that condition, you've got a 25% chance of having that. Multiple sclerosis is not that way. There's not a single gene that codes for MS. There are multiple genes. To date, we've identified over 60 genes that play a role in multiple sclerosis. And so if you have all of that perfect sort of genetic picture or pattern, you're going to be at higher risk for MS. But even if you have all of those genes in place, that doesn't mean you're necessarily going to get MS. So if you look at identical twins, where twin A has multiple sclerosis, what's the chance that twin B is going to get multiple sclerosis? These are exact genetic copies of one another, so if it was a purely genetic condition, you'd say, well, 100% of the time, twin B will get MS. It's actually about 25 to 30% of the time. So it says there is a genetic component, but there's something else. And the something else seems to be the environment. We'll talk a little bit more about that. So with the environmental factors, again, it's not one thing, it's complicated. Low vitamin D levels early in life seem to put people at a higher risk for multiple sclerosis. That, you know, we've always known that MS seems to be a little more common as you get further away from the equator. So someone like Dr. Shapiro, who's from Minnesota, they have a much higher prevalence, maybe 200, 220 per 100,000 than we do in the Atlanta metro area where I'm at. Our prevalence is around 70 per 100,000. So that sunlight exposure, sunlight plays a big role in vitamin D metabolism. That may be part of the equation. High levels of bad cholesterol recently have been linked to multiple sclerosis, and vitamin D does play some role in cholesterol metabolism, so those two things may come together. Recently, there were some interesting animal studies looking at very high salt intake and showing that that may be part of the equation. Higher salt diets may equal a higher risk of multiple sclerosis. Higher body mass index, so if you're carrying around more weight, again, one more risk factor. The place that we were born, again, may tie into that sort of sunlight exposure, and where you spend so where you're born and where you spend the first 15 years of your life. So someone born in Minnesota who at age 16 moves to Florida carries the Minnesota risk of MS for the rest of their life. Vice versa, if the person from Florida at age 16 moves to Minnesota, he or she carries that Florida risk of MS for the rest of their life. There are other genetic influences that have to do with sort of your racial makeup. So we've always known that MS is more common in people of Northern European descent. There are certain groups where it's very, very uncommon. Native Americans, so Inuits or Eskimos, very uncommon. True Africans, so on the continent of Africa, very unusual to see multiple sclerosis there. In the United States, things get a little bit more complicated because very few of us are pure anything. We're a bunch of mutts. And so if in Atlanta at the Shepherd Center, about 40 to 45% of the people that we work with are African American. We have Hispanic individuals, and that's because, again, as you get multiple generations here in the United States, we really are a melting pot sort of country. Tobacco use tobacco use early in life has been linked to a higher risk of MS. And interestingly, if you're still smoking after you have an MS diagnosis, there's a few studies that would indicate that you have more frequent relapses and maybe more severe relapses. Some of these things we put into the kind of the context of the big picture. So what does the average person with multiple sclerosis die from? The average person with multiple sclerosis dies of heart disease, cancer, and stroke, just like anyone else out there. So when you think about smoking, yeah, it's good to stop smoking for your MS, but it's probably good to stop smoking just because we all know it's associated with other bad things. So right now, as we are here, and we'll talk again later this afternoon about where we're going, for right now, the three things that we can do to help manage multiple sclerosis are either treating relapses, treating symptoms, or altering the long-term course of the illness. When we think about treating relapses, I think one of the important things to always have in the back of our mind is that, number one, when someone is early in their MS diagnosis, we say the word relapse, exacerbation, attack, as if it's always straightforward and easy and a big neon sign is going to go off on your head and you're going to know when you're having a relapse. Sometimes you might, sometimes you don't. Separating out relapses from normal fluctuation. People with MS have good days, they have bad days, good weeks, bad weeks. It may have to do with whether you're sleep deprived, whether you're stressed, whether you have a viral infection, and separating out those fluctuations versus a true relapse is not always the easiest thing in the world to do. When we think about treating a relapse, one of the foundations of the way we think about relapses is most research would indicate that whether we treat you for your relapse or we just let it run its course, you're probably going to end up at the same place ultimately. You're going to recover to the same degree in all likelihood. We just get you there faster by treating with steroids. We want to balance out the risks and the benefits. Traditionally with steroids in the United States, we're using 3 to 5 days of IV solumedrol, usually a gram a day, and then we may follow that with some oral prednisone, just depending upon whether you have any sort of withdrawal symptoms. Any Canadians in the audience? So the Canadians think we're kind of weird for using IV solumedrol. They would take that IV solumedrol dose and frequently convert that over to oral prednisone and treat your relapse with oral prednisone. It's a really big dose of oral prednisone, anywhere from 600 to 1,250 milligrams a day for 3 days. But they've got some research to suggest that they seem to get the same results with that we do with IV solumedrol. And then lastly, there's a sort of an old drug that's come back around again for relapse management. It's certainly not a first-line option. It's called Acthar Gel or ACTH. ACTH is old school. This stuff was used. It was a great relapse management used throughout the 60s and 70s. The original protocol for using ACTH was 2 weeks of daily intramuscular injections in sort of a tapering dose. What's usually done now is 5 days of subcutaneous injections just at the same dose, and then you're done with it. It's a very expensive drug. The insurance companies absolutely hate this medication. Again, it's not something that we would use as a first-line option, but if someone either doesn't respond to typical steroids or they have side effects with typical steroids, we might think about it as an option. And then lastly, if you have really a very, very severe relapse, we do sometimes do plasma exchange. So if you, say, woke up and you couldn't walk, you have a very severe transverse myelitis, and we use traditional steroids and you get no better, we may do plasma exchange over the course of about 2 weeks to try to bring back some function. Mayo Clinic has some data showing that about 50% of people who got nothing with Solumedrol did get some benefit with the plasma exchange. Managing symptoms. This is one of my favorite things to talk about. I think we've made great advances in the way we alter the long-term course of multiple sclerosis, but in terms of improving someone's quality of life right here and right now, we probably do it more through symptom management, treating someone's overactive bladder, treating someone's fatigue, treating someone's spasticity. We could speak for hours just about symptom management, but I picked out one where there was a relatively recent advance. Ampyra, a drug that was FDA approved in January of 2010, sometimes referred to as the walking drug because what they studied with this drug was the ability to walk faster with it. This is a new drug that really wasn't a new drug. This compound, dalfampridine is what Ampyra is called, is 4-aminopyridine. 4-aminopyridine is a compounded drug that's been available for decades. It was made in mom and pop pharmacies. When I started at Shepherd Center, I inherited a couple of hundred people on the 4-aminopyridine. It was not FDA approved. We would just write a prescription. You'd go to a compounding pharmacist and they would put it together for you. Frequently, insurance wouldn't cover that, so you ended up paying out of pocket, and the cost varied, depending upon the compounding pharmacist, anywhere from $35 maybe up to $70 per month. Typically, people know quickly with this molecule whether they're going to see something good with it or not. We tell people 4 weeks. If you're seeing something, if you're seeing improvement, great. In the studies with Ampyra, again, in about 4 weeks, you pretty much knew whether you were in the responder group or the non-responder group. The chances of being in that good responder group was about 40%. 60% of people just get absolutely nothing from it. And I'm not sure we understand why that is. On paper, we would think everybody would get something good from this. We would not want to use this in someone with any history of seizures. So if you have epilepsy or if you've had any sort of seizure, this drug can lower your seizure threshold and put you at risk for more seizures, so we probably would want to be careful. If you have any kind of kidney disease, we worry about you not clearing this medication and the drug building up in your system, putting you at risk for seizures, so we wouldn't want to use it in someone with severe kidney disease. The other symptom I'm going to spend just a little bit of time talking about is foot drop. So the 3 weakest muscles typically in a person with multiple sclerosis are going to be their ability to get their foot up off the floor, the ability to flex at the knee, and the ability to flex at the hip. So if you only had foot drop, so if it was just the ability to raise your toes up off the floor, if that was all that was affected, you would do something called a steppage gait. You would bring your knee up higher to clear your foot so that your toes weren't dragging. The problem in multiple sclerosis is if you have foot drop and those ankle dorsiflexors are weak, we can almost guarantee you that your hip flexors are weak. So most people with MS cannot do a steppage gait. So what people end up doing is something called circumduction. They end up swinging the leg out and around in a circle. And a lot of people with MS are not even aware that they're doing this, but if we ask their significant other, walk behind them and watch them when they're tired and see if you don't see this sort of swinging motion. The problem with circumduction is that as humans, we weren't designed to walk that way. We were designed for our legs to go this direction, not that direction. Once you start circumducting, you're going to fatigue very quickly. You're going to be more at risk for knee pain, hip pain, low back pain. So we want to avoid that if possible. So we refer you to a physical therapist. And what that physical therapist is going to traditionally recommend is an ankle-foot orthotic. Ankle-foot orthotics are wonderful for some people. Other people are not very happy with them. So why don't people like ankle-foot orthotics? Well, there's a fashion issue. If someone has shorts on, they may not want other people to see it. It may not fit in the shoes that you want it to fit in. When we did the talk in Puerto Rico, I was relaying that Shepherd Center did an interesting study years ago where they wanted to see what people were doing with their equipment, whether it was an ankle-foot orthotic, a walker, a manual chair, a scooter, a power chair. So they were able to tag these pieces of equipment with something so that you could track them with GPS, so we could tell where things went. And people's walkers went all over town. They had a great time. They went to the movies, they went to the grocery store. The ankle-foot orthotics, for some people, went two places. They went in the closet, and then the person put it on, and they went to the doctor's appointment when the person had a doctor's appointment. So the person was making us happy. That got that ankle-foot orthotic on. It looks just as new now as it did 6 months ago, and so we know that people don't like those. So what are the other options? There are toe-off devices, which are a little lighter weight. There are a lot of different versions of these, and usually they're going to be custom fit so that it's comfortable for you. These may be preferable to a standard ankle-foot orthotic. What if you just have a little bit of foot drop? So it really only is a problem when you're walking long distances. So you're on the cruise and you're walking from one end of the ship to the next, and now when you go from the bow to the stern, now your foot's dragging a little bit. Maybe you don't want an ankle-foot orthotic or a toe-off device. Maybe something simple like this would do the trick. There are a lot of different versions of this out there. This is one that we've had people pick up online. You don't need a prescription. You just go to the website, xstrap.com. And all it does is a very simple insert that goes behind your heel. It's going to lasso up over the top of your shoe, and it's going to give you a little bit of lift. It doesn't give any lateral support. If your ankle is twisting sideways, it's not going to help that at all. What it will do is, again, give you just a little bit of lift. It's cheap, it's easy, it's inconspicuous. And then we go to the high-tech stuff. What about the walk aid or Bioness devices? So we've known for 150 years that if you electrically stimulate the peroneal nerve on the outside of your knee, your foot will come up. So early on, there were devices that had a nerve stimulator that was wrapped around the outside of your leg, so that nerve stimulator was at the peroneal nerve. And then they had wires running down the back of your leg, and then there was an on and off switch in your shoe. And it worked, but it just wasn't very practical, so it's just too cumbersome. So now we have two devices out there that are realistic possibilities. We have the walk aid device. So the walk aid device has the nerve stimulator built into this little strap that goes around your knee. Built into that stimulator, there is an accelerometer and a tiltometer. When your knee goes forward, when you're trying to bring that foot up, that device senses that. It's going to fire the nerve, and make the foot come up after the nerve is stimulated. This can be worn barefoot, don't have to have shoes on. And then the competitor is from a company called Bioness. This is the Ness L300. They've now got an upper cuff that goes above the knee, so it's the Ness L300 Plus. What's the difference in this and the walk aid device? You have a clip that goes on your shoe with the Bioness device. It's a radio telemetry device, and it's sending the signal from your foot up to the stimulator to tell your foot to come up. Both of these devices have exercise mode, so you could be sitting and watching television, turn the device on, it's firing, and it may give you some exercise and help strengthen that muscle a little bit in between normal usage. What the upper cuff does with the Bioness device is it actually stimulates the knee flexor. So we can hit 2 of the 3 weakest muscles in the legs now with this device. We still haven't come up with a way of hitting the hip flexors. If you think about it, these are external nerve stimulators. If you wanted to have something that's going to stimulate the nerve to do hip flexion, it's going to be pretty cumbersome, and we're going to almost electrocute you to do it. So we're not there yet. Bioness is working, and they've been working on this for a while, with surgically implantable bions. These would be little microchips that would be implanted over the motor points so that you could get hip flexion. You would have then a little pager-like device that is your CPU, and that's going to have the program for walking that's in that. They've been teasing us with this for a couple of years now, and so we're hoping they're moving forward with that. So What are the drawbacks to these? They don't work for everybody. You definitely want to get in with a physical therapist and have them try these devices out. One of the other drawbacks is they're very pricey. The Walk-Aid device is about $5,000. The Bioness device without the upper cuff is about $6,000. You put the upper cuff on, it's about $7,000. I don't know what Dr. Shapiro's experience is. We've had horrible luck getting insurance to cover these. We've actually done some internal funding through some fundraisers to actually get these in people's hands.
You can get them used.
You can get them used. Good point. So they are refurbished. Yep, good point. So this is one of our ladies that we work with, just to give you an example of what these devices can do. So Joan is walking with a walker and her ankle foot orthotic on, and it takes her about 91 seconds to go 10 meters. She now puts on her Bioness device. She's still got her walker, and now she's down to 41 seconds to go that same distance. She cut it in half, and so basically she's walking twice as fast as she did without the device. So why is she still using a walker, if she's walking that much better? Because she also has something called sensory ataxia. She can't feel where her feet are, and so even if her strength is perfectly normal, she still walks like she's had a drink too many, and she's at risk for falling because she can't feel changes in position. And that's one thing that these devices don't fix. They're working just on that motor part. That's again why if you're going to look at one of these, you really want to get in with a physical therapist, try it out. Because in theory, we could make someone walk faster and actually put them at more risk for falling, because now they still have the balance problems, but now they're trying to go twice as fast and may have put them at higher risk for falling. So shifting over to altering the course of multiple sclerosis, this was an option that we didn't have much to talk about prior to 1993 when beta-seron came out. The goal of these sort of disease-modifying therapies is, number one, that you tolerate the drug, and this is vitally important. If we have the greatest drug ever in terms of effectiveness, but it makes you absolutely miserable with side effects, there's a pretty good chance you're not going to take that drug, or you're going to do what you do with the ankle-foot orthotic. You're going to tell us you are when you're really not, and then we'll find out later that you're really not. We'd like to prevent relapses. We would like to prevent any sort of progression of disability. We would like to prevent new lesions on MRI. So what are these drugs not designed to do? They're not symptom management drugs. So we can't emphasize this enough, because normally as humans, when we take a medication, when we take some Motrin for our headache, or you take insulin for diabetes, something gets objectively better. With insulin, your blood sugar goes down. With your antihypertensive drug, your blood pressure is more manageable. With these drugs, we hope you tolerate it, and then ideally if we saw you 5 years, 10 years down the line, and you looked exactly like you did at time 0, that's a success. We may not have improved a single thing, but we've kept you stable in the setting of a potentially progressive disease. And so that's a success. And again, a lot of people who are new to their MS diagnosis come back after starting one of these drugs and will say, this drug isn't working. I don't feel any better. And we have to sort of circle back around and say, that's the job of the second box. That's the symptom management piece. These are your insurance policy for the future. So what are the options that we have in the toolbox right now to pick from? And I will say that most of these are FDA approved for relapsing forms of multiple sclerosis, or for the person who comes in with their first attack or a clinically isolated syndrome. Well, what if you don't have a classic relapsing form of MS? What if you are primary progressive or secondary progressive? Dr. Shapiro and I were talking about this, and I think are on the same page. We don't think of relapsing forms of MS and secondary progressive MS, for instance, as being two separate boxes. It's a spectrum over time. And it's not like one day you woke up and someone magically flipped a switch in your immune system and all of the inflammation went away. It's still there. It's less obvious. So we do think that people with progressive forms of MS can potentially benefit from these drugs. Showing it in clinical trials is not always the easiest thing to do. The measure that we use in research to track disability, or EDSS, may not be the most sensitive thing in the world. It's very heavily weighted towards walking. And so just the way that we're doing research in progressive forms of MS may be putting us behind the 8 ball in terms of measuring the potential benefit that people would get from one of these medications. So we always want to be straightforward when we talk about one of these medications in a person with a progressive form of MS and say, well, this is what we know and this is what we don't know, so that we can then make an informed decision. I think what most of us are afraid of in the MS world is that the day would come when someone makes the decision for you, and that's what we don't want. We don't want a third-party payer or government agency saying, you know what, you've crossed some magical line, you're above a certain age, you've crossed a certain level of disability, and therefore you're not going to be eligible for one of these drugs. That's what we're fighting back against. The other thing that comes up when we talk about this relapsing remitting to secondary progressive, sort of transition, is that when those categories were designed, they were designed to describe the natural history of multiple sclerosis, the untreated version of MS. It's unusual in the modern sort of MS realm to see a lot of people who are completely untreated. For a lot of people with MS, we are seeing some version of your MS on treatment. So I think in some individuals what we do is we may knock the peaks off of your MS activity. We stop the relapses or make them less frequent, but we're not stopping all of the progression of disability. So technically you are progressing, but you're not relapsing, so it would be very tempting to say, well, you've got secondary progressive MS. And that may or may not be correct. If we took your treatment away from you, we may now see the active inflammation on MRI, the active relapses, so we may see a better picture. We don't like doing that experiment, and so that again, that sort of strict line between relapsing, remitting, and secondary progressive, I think that line is not as black and white as we sometimes pretend it is. So with the toolbox right now, sliding computer. We have interferon therapies. We have Avonex, we have Plegridy, we have Rebif, beta-seron, and Extavia. What's the difference between the interferons? Well, one of the differences is all of them are given subcutaneously except for Avonex, which is given intramuscularly. That doesn't affect how long the drug sticks around or how effective it is. That's just a delivery mechanism. So some people might prefer one route versus the other, but how those drugs are administered really doesn't affect the effectiveness of the drug. The biggest difference between the drugs is how much you're getting in your system on a weekly basis. And so we used to have low-dose interferon, we had Avonex, and we had high-dose interferon. We had beta-seron and Rebif and then Extavia. Well, now we've got an in-between option in Plegridy. We know in large studies, if you look at big groups of people with MS, that there is a dose response curve with interferons, that for the average person with MS, the more interferon we get in your system, the more protection you have. What we don't know for an individual is, well, where are you at on that curve? Are you someone that really has got to have that higher dose? Or are you someone that might get away with a lower dose like an Avonex or a Plegridy? And we have no blood test, we have no way of predicting that. So what a lot of MS centers do is we would tend to go with the higher dose interferon rather than taking the chance. Plegridy is our newest interferon. It does give us an interesting option. They have come up now with a process called pegylation. It makes the molecule stick around a little bit longer. So Plegridy is an every 2-week subcutaneous injection. And again, its dosing is higher than Avonex, but it's lower than beta-seron, Rebif, and Extavia. Don't have a lot of experience with that drug yet. We have a handful of people that are on it. One thing that I want to see is, are you going to see more flu-like side effects, because you're giving a pretty good slug of that drug all at once and then letting it last for 2 weeks, and I just don't have any feedback yet on whether what we see in research is going to match what we see in the real world. Copaxone, available in 2 doses, 20 milligram, 40 milligram. Novantrone or mitoxantrone was a drug that we used to use a little bit of. It is a chemotherapy. It is FDA approved for MS, and it's the only drug that is technically approved for secondary progressive MS. What are the downsides to Novantrone? We used to focus quite a bit on the risk to your heart. So this class of drugs called anthracene-diones can actually damage the cardiac muscle itself, and so we would do echocardiograms periodically to make sure that your heart was still pumping effectively. If you've ever received a dose of Novantrone, even 1 dose, you need to get yearly echocardiograms for the rest of your life, because there can be a delayed effect in terms of that cardiac damage. When the drug was approved, in the package insert, in the research, there was a mention of a risk of AML, of this leukemia. And it was felt to be about 1 in 2,000. As time went on, it was really some of the Italian researchers that sounded the alarm that it really wasn't 1 in 2,000, it was probably more like 1 in 100. And the AML is bad. We had 2 individuals develop AML on Novantrone. Both died very quickly from their AML. We had a third who was about 7 years out from her last Novantrone dose. She only had 1 in her lifetime, and then developed AML about 7 years later. Ironically, she was our son's babysitter. So they both developed AML. They were in hospitals across the street from one another, so she was very fortunate in that her brother was a perfect bone marrow match for her. So rather than going the chemotherapy route, she went straight to bone marrow transplant early in the course, and she's actually doing very well. Ironic, we'll talk some later this afternoon about bone marrow transplants as a treatment for multiple sclerosis. Not your preferred way of getting your MS treated, but I would say she's actually doing very well with her MS also and is on no treatments at this point because she has her brother's immune system. And again, we'll talk a little bit more about how that kind of fits into the scheme of things. 3 oral medications that we have now: Gilenya, Aubagio, and Tecfidera. They all have a place. I would say that of the 3, you could argue that maybe Gilenya is the most effective. Aubagio is one that we are using, and we've been fairly happy with it. Tecfidera, I think for a lot of MS centers, was the drug that we were really holding out for. It looked like it had the best safety profile of the oral medications. The effectiveness looked pretty reasonable. So we had a lot of people who were doing okay on their injectable therapy, but they just were burned out on doing shots, and they really wanted to be on a pill. So when Tecfidera came out, a lot of our patients switched over to that. We expected one speed bump with Tecfidera. We expected a lot of GI side effects and the flushing type reactions, especially in the first month of being on treatment. And what we really saw were 2 groups of people in that first month. People who did really well, they had no GI side effects, no flushing, they were thrilled with the drug. And then there was the other group who really wanted to come in and beat us up. Yeah, not happy. When we say GI side effects, some of our folks were pretty miserable. Nausea, vomiting, abdominal pain, couldn't get off the Tecfidera fast enough. The second speed bump we really didn't expect. And so in the studies with Tecfidera, about 30% of people have their lymphocyte count drop a little bit. But in the clinical trials, the lymphocyte count stayed above the lower limits of normal for almost all of those individuals. And they didn't see any higher risk of infections. What we started seeing in our Tecfidera patients at about 6 months is that their lymphocyte counts were dropping to fairly significantly low levels. We were a little more, I would say, obsessive compulsive, and so we do something called T-cell subsets in all of these individuals also. So we're breaking those lymphocytes down into what we call CD4 and CD8 cells. And we saw a group of people that we were very concerned about who actually had normal lymphocyte counts, at least they were at lower limits of normal, but still technically normal. But when you looked at how those lymphocytes broke down, their CD4 cells were very low. And you would have had no idea that their CD4 cells were low just from looking at that lymphocyte count. So in September and October, we were in the process of working with Biogen IDEC and working with the FDA, giving them this information, and really arguing that the laboratory testing that was recommended in the package insert was not adequate. What the package insert said was a blood count within 6 months of starting the drug, and then a year later, or as indicated. Well, our concern was the as indicated might be a really bad infection if you weren't looking more frequently. So we were doing the blood counts and breaking the lymphocytes down at time 0, bringing the person back at 3 months, at 6 months. If they were normal at 6 months, we would let them go then to a twice a year rotation, because all of the individuals we saw that dropped these counts did it at about the 6-month mark. When we were in the process of giving that information to the FDA in October of 2014, there was a death in Germany in one of the original study patients on Tecfidera. This individual died from PML. This individual was severely immunocompromised for 3.5 years. And so when you look at the numbers, their lymphocyte counts were very, very low. and they were low for a long period of time. So this person was seriously immunocompromised. And again, that's what we're trying to avoid. Tecfidera can be a wonderful drug. We just want to, like any of our medications, use it appropriately and try to do appropriate safety monitoring. Tysabri. So Tysabri has been sort of a roller coaster ride where, as you remember, it got approval in 2004. It was out for about 3 months, and then we had the first 2 cases of PML pop up, and it was voluntarily withdrawn from the market. People looked at the issue, the FDA, the National MS Society, multiple groups met, and the FDA let the drug come back on the market in June of 2006 with the understanding that it really wouldn't be something you would use as a first-line treatment. So we knew that PML was a risk with this drug. Initially, when the first 2 cases popped up, they popped up in the group who was on Avonex and Tysabri together, and there was some thought, well, maybe it's the combination. It's not the combination. It's the Tysabri all by itself that is the risk. We also, so PML is caused by JC virus. JC virus named for John Cunningham, the first guy who was ever described to have the virus. JC virus is a very common virus. Over 50% of the U.S. adult population carries JC virus. So where do you pick it up at? Probably in childhood. It lives in the kidneys. Well, how did it get to your kidneys? Well, it came in through your mouth. How does it get out of your body? You pee it out. So where would you pick up the JC virus in childhood? Think of swimming pools. So little Jimmy's in the pool. He just peed in the pool. Now Johnny just took a mouthful of water to spit on Bobby over here. Now they've all got JC virus. So if you go in the pool, do not drink the water, and don't go in the kiddie pool. So we knew when Tysabri came back out in 2006 that about 50 to 55% of the U.S. population carried JC virus. The problem then was, outside of research, we didn't know which 50 to 55%. So again, we were very conservative with Tysabri. We wouldn't use it as a first-line drug. We now have 2nd generation JC virus antibody testing. The 1st generation test just told us simply you have antibodies to the virus or you don't. So we could use that to say if you don't, you're in a better risk group. You could safely look at Tysabri as an option. If you have the antibodies, you're in a higher risk group, and we're probably going to think about that some. The other risk factors, if you are in the group that carries the virus, is how long you've been on the drug, so the risk goes up after 2 years, and whether you've had any prior chemotherapy agents. The trifecta of risk is someone who has the virus, someone who's been on the drug for more than 2 years, and they've had prior chemotherapy. In that group, the risk of PML gets up into the 1 in 100 range, so pretty significant. 2nd generation test took things a little bit further. So now we have a group that definitely does not carry have the antibody to the virus. And then we've got a yes group, but in that yes group, we can actually put a number to the JC virus antibody. It's called the JC virus antibody index. And so if you have an index value of less than 0.9, but greater than 0.4, you're technically positive, but your risk is actually the same as the group that doesn't carry the virus.
So we're going to talk about this a little bit more.
Yeah. Thank you guys very much. I'm going to turn it over to Alan to wrap it up for the morning.